So, welcome everyone. Today we're discussing the ins and outs of point of care ultrasound for DVT evaluation in primary care. POCUS enables accurate bedside evaluations, reduces unnecessary referrals, cuts costs, and enhances diagnostic confidence, especially when traditional imaging or labs are unavailable. Some of the barriers to POCUS implementation include concerns regarding competency and liability. We discuss strategies to help you succeed in your POCUS journey. POCUS is a transformative tool for diagnosing deep vein thrombosis or DVT in primary care. After this podcast, you will understand the benefits of POCUS for DVT rule out, basic techniques, and strategies to mitigate liability. Dr. Tatiana Haverluk is an emergency physician and founder of Hello Sono, with 15 years of experience using POCUS in diverse settings from urban EDs to Everest Base Camp. She is dedicated to extending its benefits to more patients. With Hello Sono, she and her team support practices in building compliant, high quality, and profitable POCUS programs through tailored education and implementation. Thank you, Dr. Haverluk, for being with us today.
Hello, Randy. I am so happy to be here as always.
Good, yeah, absolutely. Another POCUS podcast. Very interesting topic. So let's, I guess, jump in with sort of the first question, which is how does POCUS change the diagnostic pathway for the evaluation of DVT in primary care?
Yeah, it's huge, right? So it's giving you an answer at the bedside, basically an imaging at the bedside. So if you have a patient that you're suspecting a DVT in, you can rule it in or rule it out at the bedside and really start them on appropriate treatment. I think the big thing is that comes up, I think, when I talk to providers about this is, oh, is it as good as, the whole leg DVT scan you get in a vascular lab? And it actually, the evidence shows that it's quite good. It's really very much comparable. The sensitivity for a DVT of a proximal leg POCUS scan is in the 90s, high 90s to even 100%. There was a study that recently came out on hospitalists doing their own study, and it was 100% sensitivity after learning POCUS for 2 hours, like having a didactic session, and then collecting 10 normal scans. And after that, they were kind of on their own, just scanning patients, and they had 100% agreement with the gold standard. So it's really practice changing.
Yeah, and I think that's probably the key is that it's come a long way. And if you know how to use the tool, then you can know now. So it's not a matter of quality anymore because the technology is better.
Totally. And another thing with this, how it changes your clinical pathway is not only do you get to rule in or rule out a DVT, you can also look for other causes of patients' complaints. I'm assuming they're coming in with leg swelling or leg pain, and maybe not only DVTs in your differential, but a Baker's cyst or some kind of abscess or maybe a muscular injury or tear. And you really have a tool at the bedside to look for all of those things and manage patients more appropriately and a lot more efficiently.
So talk about a little bit about how simple it is to learn and perform the POCUS DVT rule out and how long does it take? I know you touch on it a little bit, but talk a little bit more about that learning curve.
Yeah, I would say, look, you do need some kind of didactics, right? Just to understand how are you going to obtain the views, where to put the probe. And POCUS actually is quite simple for the DVT rule out. You're literally compressing the deep veins of the proximal leg. So you're starting in the groin region, in the inguinal region, and you're compressing that common femoral vein, and where there's a confluence of deep and femoral vein and the saphenofemoral junction, but they're all within 1 or 2 centimeters of each other. So it's considered just one point of compression. And you're literally just watching the walls of the vessels touch. And then the next spot is in the mid thigh, where you're going to compress the femoral vein. And then the last spot is behind the knee in the popliteal region, where you're compressing popliteal vein. So it's really a 3-point compression of the vein. It takes me about 2 minutes. Someone who's just starting, I would tell them, give yourself 10 minutes on your first 5 patients. After you get the hang of it, after 5 patients, you will actually feel quite comfortable performing this test. And, I always tell people, you can practice on your kids, on your partner, on your family members, friends. Like, it doesn't have to be the patients, right? Where it takes you away from the clinical, maybe, clinical workload
Correct.
that you have and you're stressed and you're trying to fit this in. You can do this at home as well for the first few. But really, the learning curve is steep for the first 5 scans, and then you're kind of cruising.
Yeah. So a couple hours and then maybe an hour some didactic, like you said, just some reading and some more didactic training, and then just spending some time doing it. So that's not a steep curve at all. Just a couple hours sounds like.
Exactly. Yes. Very much doable for mid-level providers, for physicians. I mean, it is really within the scope of a lot of providers, of all the providers.
So let's get into one last question about some of the business side or the liability. So what's the liability in performing this procedure or going through this process in a primary care setting? And then I guess talk a little bit about the billing components if there's anything that you'd like to touch on there.
Yeah, of course. Well, so the liability is similar to doing any kind of point of care, a point of care test, and then interpreting it at the bedside, right? So if you do an EKG on your patient and then you read it, it's that similar liability. So really, the only way to protect yourself is make sure you are meeting the standards that currently exist for the training, for the documentation, and also making sure that you are still giving very good discharge instructions to your patient. And I would say a big one is also like using your common sense. If you're really not getting clear images when you are doing this, maybe the patient is really overweight and you're just not getting good visual of the vessel and you're not sure whether it's compressible or not. Do not make a clinical decision
Yeah.
based on that. That's the patient you do send maybe to the ER if you have really high concern, but hopefully you can schedule something outpatient promptly.
Yeah.
But it is recommended 25 scans, just educational scans to really gain some competency in doing this until you start doing this on patients and making clinical decisions. And the second, so I think that would be the biggest way to mitigate
Yeah.
risk is to make sure you got your training. If you can get the CME for all your training, that's really good too, because then you also have proof that you have completed accredited training. And another thing is this part of how do you really archive these images, right? It's one thing you did something at the bedside, like use the stethoscope, and
Yeah.
you're like, oh, I heard, crackles and I gave them antibiotics. But with POCUS, it's actually very different. You do want to save your images and have a procedure note in the chart, and that needs to be available indefinitely. And that's actually what's going to protect you if there's an issue, if there's a lawsuit, for example. You can go to those images and show the compression scan that you did, and hopefully it would be of good quality, if you completed the training. But that's how you would protect.
And those types of things, when you do the implementation, when you take the step to implement POCUS, you put all of those things in place, making sure your images are backed up, you have storage and all of those things that are
Exactly.
more IT related. But yeah, that's pretty straightforward. Um, so what are your three little key clinical pearls or smart bites of information that you would want to share to just sort of summarize?
I would say number one is that POCUS, especially for this DVT rollout, is within your scope of practice. And there are tools available. So really don't limit yourself. I would say, do it. Those 3 sentences.
Yeah, there you
Sorry,
go.
that was not a small tidbit. Um, I mean, another thing that the sensitivity of this test is comparable to, the vascular full leg vascular studies, 96 to 100%.
Yeah.
So that's really reassuring. what's my third one? I wasn't ready for this.
That's
Uh,
okay. If there's not a third one, that's okay. If three was
I,
arbitrary.
I mean, I'm thinking my third one, we didn't discuss, the reimbursement for these, but the Medicare reimbursement for a unilateral DVT rollout, is $115 for a global fee. So this is something that you're bringing into your practice and you're investing into the training and the equipment. There's really an ROI in it as well that, it kind of pays for itself.
Yeah, and see, that was the good. You got the third one with no problem once it came.
Yes.
Well, thank you very much. This was very informative as always, and we look forward to our next focus.
Awesome. Thank you so much, Randy.
Please support our mission to improve quality of patient care through education. Join us, follow us, and share this content with family and friends.